allons appeler l'équipe LIVERNEAUX, Salazar, IGETA, FACCA, HIDALGO et DIAZ pour Prothelast à propos d'un nouveau concept de prothèse totale de poignet isoélastique. Vous avez 8 minutes.
Mr. Chairman, dear colleague, we have developed a new concept of wrist total prosthesis called Prothelast. So on behalf of Professor LIVERNEAUX, I will present the surgical techniques and follow-up of 5 clinical cases of a new total and isoelastic wrist implant. One of authors has a conflict of interest with several companies. The survival rate of prosthesis, as known as remotion prosthesis, is over 19% at 8 years. But recently, it has been shown the survival rate drops 20% after 10 years. In here, survival means the time until the revision is required because of complication. This is one of the patient follow-up for 4 years. You can see in the blue circle, there is osteolysis around the lateral implant. And most frequent complication described by Gersper is loosening around the square of carpal implant. You can see in the red circle. So how to change the history of prosthesis? First of all, the carpal implant changes the direction of attachment to the carpal bone. Unlike conventional implants that attach vertically to the sagittal plane, the Prothelast attaches horizontally. This idea is partly from the spider plate. And this is supposed to avoid the distal migration and the clasp of the screw in the base of the metacarpal bone. On the other hand, the lateral component is designed with a long central majority K-wire using the principle of isoelasticity for hip prosthesis, described by BOTERO. Conventional prosthesis with short stem gain primary stability by the principle for press fit and concentrate the stress only around the distal radius. But Prothelast is supposed to allow the distribution of the force throughout the radius and preserve the anatomical length even if the stock bone is not enough. We operated 5 patients using Prothelast total wrist arthroplasty. Age is between 59 and 75 years old. 3 males and 2 females. 2 patients were performed on dominant side and 3 on the non-dominant side. 3 patients' diagnosis is wrist osteoarthritis by chondrocarcinosis, and 2 are rheumatoid arthritis. First, we performed the dorsal approach and opened the fourth extensor compartment. And this patient is a rheumatoid arthritis, so we do the ulnar head osteotomy and open the capsule like this. And in order to make the place for the implant, we do the proximal row carpectomy, and we insert the drilling guide, and we check the position on the fluoroscopy, like that. And we insert the K-wire to the subconjunctival bone of radial head, and we rasp the radial bone. And we put the trial, and we remove the K-wire, and we fix the trial and carpal trial. We check the movement, and we fix the definitive implant with a screw, and we cut the K-wire definitive length with this device, and we connect the radial implant to the K-wire with screw, and we fix and finally we check the ligament balance. Then suture the capsule and retina column and close the skin. So this is the post-operative result compared to the pre-operative measure of the quick dash score range of motion after the average follow-up. The improvement of the quick dash is visible in the patient of the osteoarthritis or by chondrocalcinosis, whereas patient of the rheumatoid arthritis don't show the significant improvement. Pain was measured by visual analog scale. We can see the significant improvement post-operatively in patient with chondrocalcinosis osteoarthritis, as opposite to the patient with polyarthritis. The grasp measured by Germer was improved in all patients post-operatively. Here is the clinical result of the all patient. We can see the longer follow-up in the rheumatoid arthritis patient, and there are some osteoarthritis around the screw of the carpal implant in rheumatoid arthritis patient. So in conclusion, there are the latest X-ray of the list of all patients. In conclusion, these preliminary results show the same result compared to the short-term result of the other prostheses described in the literature. We will continue to follow up the patient to make sure that the long-term results are as satisfactory as the short-term result. Thank you for your attention.
Thank you very much. It was a nice presentation. Does this prosthesis get osseointegrated, or does it leave room for micromotion?
We think of micromotion because this is isoélastic, so maybe after I will present the uni-compartmental prosthesis, so I will explain that. So.
Okay, I think LIVERNEAUX told me that on purpose he wants some micromotion to stimulate the bone and avoid this stress shielding induced osteolysis that we have been talking about before. Yes. Are there any questions from the floor?
Just one question.
Yes.
Thank you for your talk. Is this prosthesis already commercialized in France, or is it just in your department?
Maybe already commercial, but
only in France?
Only France, because I'm from Japan, so I can do.
No. Yeah. And just a comment now, I think it's a brilliant idea to develop a distal component that is not going axial, but that's going on top. Because in my experience, the axial composition is one of the Achilles tendons of all the distal anchoring of the prosthesis, because it loosens always. I mean, that's the weak part. We sometimes have proximal problems, since we can have giant celled reactions, etc. But that is very exceptional. It's always at the distal part, and I think that might be a good way to innovate and to find a solution to this very annoying problem.
Yeah, thank you.
More questions? If not, thank you very much.
Thank you.
And